Bismillah ar-Rahman ar-Rahim. I start with the name of Allah, the Lord of Mercy, the Giver of Mercy. I am Dr. Muhammad Yusuf Hawan. I'm the consultant physician currently working in one of the NHS hospitals. As we discussed in the previous session in localization of neurological lesion, I discussed about whenever we come across any patient with a neurological problems, we need to ask ourselves, where is the lesion? That means we need to localize the lesion in any part of the brain. And once we have localized the lesion, then we think about what is causing that lesion. So, and that is about any particular disease which is responsible for these symptoms and signs. So from where to what, so I'll be starting today to discussing one of the diseases which are more common, which are causing neurological deficits in in major part of the elderly population, and can have the effect in younger people as well. So we'll starting with the cerebrovascular diseases, and the first part will be about the TIA, that is transient cerebral ischemic attack, and the stroke. And the second part will be about the hemorrhagic stroke. And the third part, I'll discuss about some of the guidelines, especially the updated national guidelines in the UK about the stroke management and investigation and management of the stroke. All right, the cerebrovascular disease, which would divide into three categories. One is the transient cerebral ischemic attack. As the name indicates, this is just a transient neurological problem, and it resolves within a certain period of time. And the ischemic stroke means when there is definitely some neurological damage to the brain, and that results in some permanent neurological deficit. And because of the ischemia or the occlusion of the blood vessel, and a part of the stroke, which is due to the bleeding in the brain, is called hemorrhagic stroke. So the common stroke among the ischemic and hemorrhagic stroke is the ischemic stroke, which is responsible for more than 85% of the patients, and hemorrhagic stroke usually is responsible for 15% of the patient presenting with the stroke signs and symptoms. So we'll start with the question. 64-year-old man with a history of hypertension and diabetes presented with right-sided weakness, which improved after about 1 hour. His medication included metformin, atorvastatin, and ramipril. Neurological examination was normal at the time of presentation. CT head was normal. Neurovascular imaging showed 40% of stenosis of the right carotid artery. ECG and echo were also normal. Which of the following is the most appropriate treatment in this patient? Heparin, rivaroxaban, aspirin, and clopidogrel, and the warfarin. You can pause the video, think over it, and restart after about 1 minute. So, reviewing the text of the question, this is some neurological problem, the weakness of one side of the body, which resolved within 1 hour. And at the time of presentation, the neurological examination is normal. That means this probably is transient ischemic attack, some neurological deficit which was transient and which recovered completely within 1 hour. So in the TIA, the management will discuss in the subsequent slides. The immediate thing is which can prevent the establishment of the stroke is aspirin and clopidogrel. Heparin is not usually indicated in these patients. Rivaroxaban we usually use for the people who have got atrial fibrillation, and that the embolic stroke is the consideration. Warfarin is usually nowadays used only for the valvular atrial fibrillation and the valvular problem resulting in embolic stroke and the neurological problem with the valvular problem in the heart. So the correct answer in this question is aspirin and clopidogrel starting immediately for the TIA. So let's discuss about the TIA. The transient focal neurological deficit resulting from ischemia, rather than infarction. And by definition, the absence of infarction on the neuroimaging is the defining factor in the definition of TIA. And this is independent of the duration of the symptom, but usually the symptom lasts for 5 to 60 minutes, but by definition up to 24 hours. So any neurological symptom resulting from the vascular ischemia and recovering within 24 hours, by definition, it is TIA. But most of the time when the TIA symptoms resolve within 60 minutes. So again, irrespective of the duration of the symptom, is the absence of infarction or absence of the permanent damage to the brain tissue, which is defining TIA. And the stroke is the sudden focal neurological deficit caused by ischemia or hemorrhage. So we'll discuss stroke in the later part of this presentation. So the symptoms usually depend upon the vessel which is supplying any particular part of the brain. And there was the anterior circulation, the posterior circulation, anterior cerebral artery, middle cerebral artery, or posterior cerebral artery. So depending upon the area of the brain supplied by any particular vessel involved and responsible for the TIA, could be the symptom could be the hemiplegia, weakness, one side of the body, the visual loss of the field losses in the vision, difficulty in speech, the producing the words, or producing the sounds, and difficulty in the perception of the speech, or any sensory loss. So the transient symptom of stroke, usually ischemic stroke, usually lasts from 20 minutes to less than 24 hours, as I mentioned earlier. So the concern at the moment is how can we prevent the stroke in the patient who are presenting with the TIA. Then one of the risk stratification score used is what is called ABCD2 score. This is the score to assess the severity of the TIA and what are the likely chances of this patient developing a stroke in subsequent days or weeks. This is not very sensitive, I must mention from the very beginning, and is not recommended by the national guidelines in the UK, but it still helps in establishing the severity of the symptoms and guides non-neurologist physician to when to refer the patient to the stroke specialist team or when to admit the patient. But the national guidelines, UK national guidelines, recommend that any patient who presents with transient neurological symptoms should be immediately referred to the stroke specialist team or the neurologist, and they should be seen within 24 hours and work up for that. So, but basically the ABCD score is for the age is more than 60, the scores 1. Blood pressure is 140 or 90 or more than that, the score 1. Clinical symptoms of speech deficit, score 1. Hemiparesis, the weakness of one side, the scores 2. Diabetes is score 1. And duration of the symptoms less than 59 minutes is 1, and more than 60 minutes is 2. So score of more than 3 is usually recommended that these patients should be remitted immediately to the hospital. Imaging should be done, and the immediate management should be started with these patients. The score of 4 or more than 4 is a high risk of stroke in the next 2 weeks. But still, I must remind that this score is not very sensitive. Anybody presenting with neurological symptoms should be referred to the stroke specialist team immediately, and that they should be seen by the stroke specialist team within 24 hours. So how do we investigate these patients? The imaging of the brain is really very, very important to diagnose the TIA or exclude the stroke. As I mentioned earlier, by definition, absence of infarction is TIA. So we need to rule out infarction or hemorrhage in these patients. So the first investigation recommended is either the CT head or the MRI. MRI is preferred, but usually takes time and is not available in most of the hospitals. But the CT head is generally available and should be done immediately. If the CT head is normal, and by definition is TIA, the diffusion-weighted imaging is preferred for the MRI. And if we're still thinking of uh, neurological problem, then the non-invasive imaging, the internal carotid arteries, especially CT angio, MR angio, or transcranial Doppler ultrasound, should be done in the next couple of days. The ECG is really important, the baseline ECG, to rule out any arrhythmia or atrial fibrillation. And in the absence of atrial fibrillation, arrhythmia, and ECG, and if still thinking of embolic issues or the cardiac issues, may need long-term telemetry, and long-term monitoring of the cardiac rhythm. Echo, if the cardiac cause of stroke is suspected, especially any valvular lesion and the valvular or intracardiac thrombus, or if all other causes have been excluded and still thinking of embolic stroke, so we should think of petriferamin OLA. So treatment of TIA, that the immediate treatment is that starting the aspirin and the clopidogrel. The starting dose, there's 300 milligram of aspirin and 300 milligram of clopidogrel on the first day, and then the guidelines recommend that 75 milligram of aspirin and 75 milligram of clopidogrel daily should be continued for at least 21 days, and then the monotherapy with clopidogrel should be continued for a year, rest of the life. The rest of the treatment is the same this for the secondary prevention, as we recommend in all the patients with any cardiovascular cardiovascular disease. So high dose statin, the anticoagulation for atrial fibrillation, treatment of hypertension and diabetes, lifestyle modification. So we must address all the risk factors or are contributing toward increased risk of cardiovascular disease or cerebrovascular disease or ischemic heart disease. The vascular imaging is done in most of the patients presenting with the TIA, and that is to see how are the carotid arteries, and if there is stenosis of the carotid arteries more than from 50 to 99%, then the patient should be referred to for the carotid endarterectomy if the stenosis is more than 50 to 99%. And this should be usually be done within 2 weeks. Right. So next question is 60 years old male was brought to the A&E. He woke up in the morning well, but after taking shower, developed weakness of the left arm. It took 2 hours to get the ambulance and reach A&E. The blood pressure was 170 over 96. On examination, it's found to have the left-sided hemiplegia and hemineglect and left-sided hemianopia. I'll not go into the definition of these things. We already discussed in our previous lectures on localization of the lesion. The capillary blood glucose and the CT head were normal, so there was no hypoglycemia, and there was no immediate finding on the CT head. That means we rule out in bleeding. ECG showed atrial fibrillation. So what is the most appropriate step in the treatment? The IV heparin, IV TPA, tissue plasminogen activator, high dose aspirin, or mechanical thrombectomy. So this patient presents with 2 hours history of the weakness of one side of the body, and more or less is more or less with the persistent weakness, and he was fine in the morning. We know when did the symptoms start. This is really important to define the time of onset of the symptom, because that affects the treatment, choice of the treatment in these patients. So we know that he woke up well in the morning, and then he developed the symptoms, and after 2 hours he presented to the A&E. So it has a duration of symptom for almost 2 hours. So and then it probably had AF. So the CT head has ruled out intracranial bleed. So we need to treat this patient as ischemic stroke. And the treatment for out all these options for ischemic stroke is IV, tissue plasminogen activator, or thrombolytics. I will discuss in detail in subsequent slides. IV heparin is not recommended for the stroke, but it's for the stroke, DVT prophylaxis subsequently, but it's not the treatment of ischemic stroke. High dose aspirin will not be very effective immediately. But mechanical thrombectomy we do in patients with stroke, but that is not the primary treatment. That is usually done after TPA or tissue plasminogen activator or thrombolytics. So it's ischemic stroke usually the causes for the ischemic stroke could affect the large vessels or the small vessel disease or within the brain, or could be cardioembolic, that emboli coming from the heart, emboli going to the brain and causing damage to the brain, resulting in the stroke manifestation. And there are other miscellaneous causes like hypercoagulable state and the sickle cell disease. So large vessel disease, like and the atherosclerosis is the most common problem affecting the cardiovascular, heart, coronary artery, the cerebrovascular arteries, peripheral arteries. So that could be the result, could be the reason for ischemic stroke. The embolic occlusion are usually from the heart, as atrial fibrillation or valvular problem, or the heart failure with intracardiac clots. So that could cause the ischemic stroke, affecting the large vessels. Dissection of the large vessels, carotid artery dissection, or whatever artery dissection, basilar artery dissection, could be the reason for ischemic stroke. Small vessel disease is the same. The risk factors are the same for the heart, the brain, and peripheral vessels, hypertension, hyperlipidemia, and diabetes, and genetic disorders. So embolic disease, the most really important thing to rule out or confirm is atrial fibrillation and the heart failure. But if you're still thinking of cardiac embolic stroke and we don't find any cause despite the prolonged monitoring, cardiac monitoring for atrial fibrillation, and that has been excluded, or the heart failure has been excluded, must think of FP, patent foramen valley, because closure of the patent foramen valley can result, can prevent the further ischemic strokes. Hypercoagulable saved, the protein C deficiency, protein S deficiency, factor V laden, not routinely done, but if these are the factors which could result in ischemic stroke and the sickle cell disease, causing ischemia with vascular issues. So the treatment is, the immediate treatment is thrombolytics. Once we have ruled out the intracranial bleed with the stroke, with the CT head, then that should be done. How is within 4.5 hours of the onset of symptoms. So the first treatment is thrombolytics, and this can prevent subsequent disabilities in 3 months. So the disabling stroke symptoms presenting within 4 to 5 hours of onset or from the last seen normal. If the patient woke up in the morning, that means normal, and then he developed the symptoms, that is the time of symptom of onset. But if the patient slept from about, say, midnight, 11 p.m., and in the morning he woke up with the neurological symptom, and sometime during the sleep he developed this neurological problem, then we calculate the time from the midpoint of the sleep. That is when the time when he slept at night and time when he woke up in the night, and the middle of it. And from that point is it taken plus the time it took up after waking up and presenting to the A&E or to the medical care facility. And this reduces disability at 3 months, and exclusion criteria are similar to those of the coronary thrombolysis, intracranial bleed, or history of bleed previously, the blood pressure more than 185, 110, and then this should be reduced to less than this blood pressure. So like that, the same contraindication apply to the thrombolytic in ischemic stroke. And then the subsequent treatment after the thrombolysis is aspirin, usually started with 24 hours after thrombolysis, not before thrombolysis. And control of the sugars. So if the blood sugars are more than 7, should be started with insulin, and the target blood sugar level are 7 to 15. So keep the level from 7. Don't usually start insulin at 7, but the target, we need to keep the sugar levels, blood glucose level between 7 and 15. And if they're more than 15, probably need to start with insulin. So pharmacological VTA prophylaxis can be started within 24 hours after the thrombolysis, but intermittent pneumatic compression can be started if there is any contraindication for pharmacological VTA prophylaxis. And this intermittent pneumatic compression should be continued for at least 30 days if the patient is still in the hospital, or if he or she is discharged earlier than that. So treatment of hypertension in the ischemic stroke. So if the thrombolytic treatment is not planned or the patient is out of that window period, so hold antihypertensive treatment unless the systolic blood pressure is more than 220 and diastolic more than 120. If the systolic blood pressure is 210 and diastolic less than 120, so probably doesn't need any treatment for hypertension. But if thrombolytic therapy is planned, then the target blood pressure levels are less than 185 and 110 diastolic before starting the treatment. And this should be done with IV labetalol and nicardipine, because we really need to save the time and continue. So we start with thrombolytic treatment within the window period. And the target maintenance blood pressure is less than 180 or 105 for at least 24 hours. Secondary prevention of the ischemic stroke is the same for the stroke as is for the heart. Aspirin, long-term aspirin plus dipyridamole is superior to aspirin alone. So, but the incidence of bleeding increases with combination of aspirin and dipyridamole. Clopidogrel is equivalent to aspirin and dipyridamole. We can use aspirin and clopidogrel with high-risk patients, and these should be continued for at least 21 days after the high-risk TIA or minor stroke. And after 21 days, either aspirin or clopidogrel alone should be continued. So our next aspect of the management in ischemic stroke is if we've done the carotid Doppler and we found that there's carotid stenosis more than 50%, from 50 to 99%. Previously, it used to have some of the countries still using this the threshold for stenosis of more than 70%, but the national guideline for the UK now recommends from 50% to 99% stenosis, and indication for carotid endarterectomy after thrombolysis. And this the maximum benefit from this one is within 2 weeks. This usually there's clot extraction with some devices which can just extract the clot, and this can reduce the disability, the long-term disability. And another aspect is closure of the patient foramen valley. If the patient age is less than 60 years and their embolic stroke of unknown origin, we really don't know what is the source of embolic stroke, but there is a strong suspicion of embolic stroke, then probably we should investigate for patient foramen valley and recommend for its closure. And there's no alternate cause of the stroke. Right. Question 3. 72-year-old female with no previous medical history reported to A&E with with an episode of right-sided weakness and inability to speak 2 days back. Symptom persisted for 3 hours. Clinical examination was normal. CT head was normal. CT angio showed 70% stenosis of the left internal carotid artery. Which of the following is the most appropriate next step to reduce the risk for stroke? warfarin, carotid stenting, carotid endarterectomy, or clopidogrel. So this, the lady with the weakness, the symptom persisted for 3 hours, but presented with the 2 days duration of all these symptoms. But now the current Doppler is showing that the stenosis are more than 70%. So she is a candidate for carotid endarterectomy. Stenting is not usually recommended because it leads to more complications, and is not better than endarterectomy. Warfarin is indicated only in the patient who has valvular problem with atrial fibrillation, and clopidogrel will not be effective for this patient. It's not so treatment. The correct answer for this question is carotid endarterectomy. So with the carotid artery disease, risk factors are the same as coronary artery disease, and those should be addressed. Control of hypertension, diabetes, hyperlipidemia, high dose statins, and this should be started with all the patients with any cerebrovascular disease. The stroke mechanism in these patients usually the plaque rupture and artery to artery embolism. So low flow due to the stenosis. High risk or extracranial internal artery stenosis are more than 70% plus TIA, and the stroke risk is the highest within 2 weeks of TIA. So these patients should be referred to the stroke unit and to the facility where stroke extraction can be done, and this should be done within 2 weeks of onset of symptom. So this is done by the CT angio, MRI of the MR angiography, carotid Doppler ultrasound, and consider revascularization for primary prevention of stroke if either stenosis is more than 70% or there's rapid progression of the stenosis over 3 months, and it was 60%, and then 3 months before it was 60%, is rapidly progressing to 70%. Then these are the candidates for carotid endarterectomy. So symptomatic carotid artery disease needs revascularization within 2 weeks after stroke or TIA with 50% of stenosis. Endarterectomy is preferred. Low risk of procedural stroke. Avoid stenting of the affected artery, and because this results a higher risk of procedural stroke. The medical management of intracranial stenosis is stenting, not superior to medical treatment, and as usually is monotherapy, aspirin monotherapy, but with all other addressing to the risk for atherosclerotic diseases. So that's all for today. Thank you very much for listening to this video, and if you have any feedback, please, this is my email, and you can access this video on the YouTube, and this is my YouTube link. Thank you so very much.